What does inflammation allow? Allows inflammatory cells, plasma proteins, e.g., complement, and fluid to exit blood vessels and enter the interstitial space. Inflammation is divided into what? Divided into acute and chronic inflammation. What is inflammation characterized by? The presence of edema and neutrophils in tissue. Inflammation arises in response to what? Infection, to eliminate pathogen, or tissue necrosis, to clear necrotic debris. Innate immunity. Immediate response with limited specificity. What are the mediators of acute inflammation? Toll-like receptors, arachidonic acid, AA, metabolites, mast cells, complement, Hageman factor. Toll-like receptors. Present on cells of the innate immune system, e.g., macrophages and dendritic cells. TLR activation results in what? Upregulation of NF-κB, a nuclear transcription factor. What does NF-κB do? Activates immune response genes leading to production of multiple immune mediators. TLRs and chronic inflammation. They are also present on cells of adaptive immunity, e.g., lymphocytes, and play an important role in mediating chronic inflammation. Arachidonic acid, AA, metabolites. 1. AA is released from the phospholipid cell membrane by phospholipase A2 and then acted upon by cyclooxygenase or 5-lipoxygenase. Where are mast cells located? 1. Widely distributed throughout connective tissue. How are mast cells activated? 1. Tissue trauma. 2. Complement proteins C3A and C5A. 3. Cross-linking of cell surface IgA by antigen. Mast cells' immediate response involves the release of preformed histamine granules, which mediate vasodilation of arterioles and increased vascular permeability. Mast cells' delayed response involves production of arachidonic acid metabolites, particularly leukotrienes. Complement. Pro-inflammatory serum proteins that complement inflammation. Where is complement located? Circulators and active precursors. Activation of complement occurs via what? Classical pathway, alternative pathway, MBL pathway. Classical pathway. C1 binds Ig or IgM that is bound to antigen. Alternative pathway. Microbial products directly activate complement. Mannose binding lectin pathway. Mannose binding lectin, MBL, pathway. MBL binds to mannose on microorganisms and activates complement. All pathways of complement result in production of C3 convertase, mediates C3. Greater than C3A and C3B, producing C5 convertase, mediates C5. Greater than C5A and C5B. What forms the MAC? C5B complexes with C6-C9 to form the membrane attack complex, MAC. C3A and C5A. Anaphylotoxins. Trigger mast cell degranulation, resulting in histamine-mediated vasodilation and increased vascular permeability. C5A. Chemotactic for neutrophils. C5B. Opsonin for phagocytosis. MAC. Lyses microbes by creating a hole in the cell membrane. Where is Hageman factor, factor 12 produced? An active pro-inflammatory protein produced in liver. How is Hageman factor, factor 12, activated upon exposure to subendothelial or tissue collagen? Hageman factor, factor 12, activates what? 1. Coagulation and fibrinolytic systems. 2. Complement. 3. Kinase system. Kinase system. Kinase cleaves high molecular weight kininogen, HMWK, to bradykinin, which mediates vasodilation and increased vascular permeability, similar to histamine, as well as pain. What are the cardinal signs of inflammation? Redness, rubor, and warmth, calor, swelling, pain, fever. What is redness, rubor, and warmth, calor, due to? 1. Due to vasodilation, which results in increased blood flow. How does redness, rubor, and warmth, calor, occur? Occurs via relaxation of arteriolar smooth muscle. Key mediators of redness, rubor, and warmth, calor, are histamine, prostaglandins, and bradykinin. Swelling, tumor, is due to what? Due to the leakage of fluid from postcapillary venules into the interstitial space, exudate. What are the key mediators of swelling? 1. Histamine, which causes endothelial cell contraction, and 2. Tissue damage, resulting in endothelial cell disruption. Pain, Bradykinin and PGE2 sensitize sensory nerve endings. What are the steps in neutrophil arrival? Margination, rolling, adhesion, transmigration and chemotaxis, phagocytosis, destruction of phagocytosed material, resolution. Step 1. Marginatum. 1. Vasodilation slows blood flow in postcapillary venules. 2. Cells marginate from center of flow to the periphery. Step 2. Rolling. 1. Selectin speed bumps are upregulated on endothelial cells. 2. Selectins bind Cl Lewis X on leukocytes. 3. Interaction results in rolling of leukocytes along vessel wall. E-selectin is released from where and what does it mediate? Release from Weibel-Palade bodies, is mediated by histamine. E-selectin is induced by what? TNF and IL-1. Leukocyte adhesion deficiency is most commonly due to an autosomal recessive defect of integrins, CD18 subunit. Step 4. Transmigration and chemotaxis. 1. Leukocytes transmigrate across the endothelium of postcapillary venules and move toward chemical attractants, chemotaxis. Neutrophils are attracted by bacterial products, elate, C5a, and LTB4. Chediak-Higashi syndrome is a protein trafficking defect, autosomal recessive characterized by impaired phagolysosome formation. Clinical features of Chediak-Higashi syndrome include increased risk of pyogenic infections, neutropenia, giant granules in leukocytes, defective primary hemastasia, albinism, peripheral neuropathy. Why is there neutropenia in Chediak-Higashi syndrome? Due to intramedullary death of neutrophils. In Chediak-Higashi there are giant granules in leukocytes because due to fusion of granules arising from the Golgi apparatus. In Chediak-Higashi defective primary hemastasia is due to abnormal dense granules in platelets. NADPH oxidase. O2 is converted to O2 by oxidative burst. SOD. O2 is converted to H202 by superoxide dismutase. MPO. H202 is converted to HOCl, bleach by myeloperoxidase, MPO. CGD is characterized by poor O2-dependent killing. CGD is due to NADPH oxidase defect, X-linked or autosomal recessive. MPO deficiency results in defective conversion of H202 to HOCl. MPO deficiency symptoms. Increased risk for candida infections, however, most patients are asymptomatic. MPO deficiency and NBT. Normal, respiratory burst O2 to H2O2 is intact. O2 independent killing. Less effective than O2 dependent killing and occurs via enzymes present in leukocyte secondary granules, e.g., lysozyme in macrophages and major basic protein in eosinophils. Step 7. Resolution. Neutrophils undergo apoptosis and disappear within 24 hours after resolution of the inflammatory stimulus. Macrophages. Macrophages predominate after neutrophils and peak 2 to 3 days after inflammation begins. What are macrophages derived from? Monocytes in blood. How do macrophages arrive in tissue? Via the margination, rolling, adhesion, and transmigration sequence. What are the outcomes for macrophages managing the next step of the inflammatory process? Resolution and healing. 2. Continued acute inflammation, abscess, chronic inflammation. Macrophages induce resolution and healing by anti-inflammatory cytokines 1L10 and TGF-beta are produced by macrophages. Macrophages induce continued acute inflammation by persistent pus formation. Chelate from macrophages recruits additional neutrophils. Macrophages induce abscess by acute inflammation surrounded by fibrosis. Macrophages mediate fibrosis via fibrogenic growth factors and cytokines. Macrophages induce chronic inflammation by macrophages present antigen to activate CD4+ helper T cells, which secrete cytokines that promote chronic inflammation. Chronic inflammation is characterized by presence of lymphocytes and plasma cells in tissue. It's a delayed response but more specific, adaptive immunity than acute inflammation. T lymphocytes are produced where? Produced in bone marrow as progenitor T cells. T cells use TCR complex 4, TCR and CD3 for antigen surveillance. Activation of T cells requires what? 1. Binding of antigen, MHC complex, and 2. An additional second signal. Activated CD4+ helper T cells do what? Secrete cytokines that help inflammation and are divided into 2 subsets. What are the subsets of activated CD4+? Th1 and Th2. Th1 subset secretes IL-2, T cell growth factor and CD8+ T cell activator, and IFN gamma, macrophage activator. Th2 subset. EL4, EL5, EL10. Th2 subset secretes EL4, which results in facilitates B cell class switching to Ig and Ig-A. Th2 subset secretes EL5, which results in eosinophil chemotaxis and activation, maturation of B cells to plasma cells, and class switching to IgA. Th2 subset secretes EL10, which inhibits Th1 phenotype. What provides the second activation signal for CD8+, EL2 from CD4 plus Th1 cell? Cytotoxic T cells are activated for killing. B lymphocytes. Immature B cells are produced in the bone marrow and undergo immunoglobulin rearrangements to become naive B cells that express surface IgM and IgD. What provides the second activation signal? CD40 receptor on B cell binds CD4OL on helper T cell. What happens after the second activation of B cells? Helper T cell then secretes EL4 and EL5, mediate B cell isotype switching, hypermutation, and maturation to plasma cells. What is granulomatous inflammation? Subtype of chronic inflammation, characterized by granuloma, which is a collection of epithelioid histiocytes. What are epithelioid histiocytes? Macrophages with abundant pink cytoplasm, usually surrounded by giant cells and a rim of lymphocytes. What is granulomatous inflammation divided into? Non-caseating and caseating subtypes. What is non-caseating granulomas? Lack central necrosis. Common etiologies for non-caseating granulomas include reaction to foreign material, sarcoidosis, beryllium exposure, Crohn disease, and cat scratch disease. Caseating granulomas exhibit central necrosis and are characteristic of tuberculosis and fungal infections. What is DiGeorge syndrome? Developmental failure of the third and fourth pharyngeal pouches. What is DiGeorge syndrome? Due to 22q11 microdeletion. What does DiGeorge syndrome presents with? T-cell deficiency, lack of thymus, hypocalcemia, lack of parathyroids, and abnormalities of heart, great vessels, and face. Severe combined immunodeficiency, defective cell-mediated and humoral immunity. What are the etiologies for SCID? Cytokine receptor defects, adenosine deaminase, ADA, deficiency, MHC class II deficiency. Cytokine receptor defects. Cytokine signaling is necessary for proliferation and maturation of B and T cells. Adenosine deaminase, ADA, deficiency. ADA is necessary to deaminate adenosine and deoxyadenosine for excretion as waste products. Buildup of adenosine and deoxyadenosine is toxic to lymphocytes. MHC class II deficiency. MHC class II is necessary for CD4 plus helper T cell activation and cytokine production. SCID is characterized by susceptibility to fungal, viral, bacterial, and protozoal infections, including opportunistic infections and live vaccines. SCID treatment is sterile isolation, bubble baby, and stem cell transplantation. What is X-linked to gammaglobulinemia? Complete lack of immunoglobulin due to disordered B cell maturation. Naive B cells cannot mature to plasma cells. What is X-linked to gammaglobulinemia due to mutated Bruton tyrosine kinase, X-linked? What is the caveat associated with X-linked to gammaglobulinemia? Live vaccines, e.g., polio, must be avoided. What is common variable immunodeficiency? Low immunoglobulin due to B cell or helper T cell defects. CVID increases the risk of what? Increased risk for bacterial, enterovirus, and Giardia lamblia infections, usually in late childhood, increased risk for autoimmune disease and lymphoma. IgA deficiency. Low serum and mucosal IgA, most common immunoglobulin deficiency. IgA deficiency increases the risk for increased risk for mucosal infection, especially viral. However, most patients are asymptomatic. Hyper-IgM syndrome. Characterized by elevated IgM, due to mutated CD4OL, on helper T cells, or CD40 receptor, on B cells. What is the effect of the mutation leading to hyper-IgM? Second signal cannot be delivered to helper T cells during B cell activation, so cytokines necessary for immunoglobulin class switching are not produced. No class switching in hyper-IgM syndrome leads to what? Low IgA, Ig, and IgA result in recurrent pyogenic infections due to poor opsonization, especially at mucosal sites.
What is Wiskott-Aldrich syndrome? Characterized by thrombocytopenia, eczema, and recurrent infections, defective humoral and cellular immunity.
What is Wiskott-Aldrich syndrome due to? Mutation in the WASP gene, X-linked. What are the complement deficiencies? C5-C9 deficiencies, C inhibitor deficiency. C5-C9 deficiencies. Increased risk for Neisseria infection, in gonorrhea and N. meningitis. C inhibitor deficiency results in hereditary angioedema, which is characterized by edema of the skin, especially periorbital, Fig. 2.3, and mucosal surfaces. Autoimmune disorders are characterized by immune-mediated damage of tissues, 1% prevalence in the U.S., involves loss of self-tolerance. Autoimmune disease is more common in women, classically affects women of childbearing age. What is the etiology for autoimmune disease? It is likely an environmental trigger in genetically susceptible individuals, increased incidence in twins and associated with certain HLA subtypes. Systemic lupus erythematosus is more common in women, especially African American females. Anemia, thrombocytopenia, or leukopenia in SLE is due to autoantibodies against cell surface proteins. Most common causes of death in SLE: renal failure and infection. What is a classic finding for systemic lupus erythematosus? Liebman-Sachs endocarditis is characterized by small, sterile deposits on both sides of the mitral valve. What is the most common clinical features of systemic lupus erythematosus? Diffuse proliferative glomerulonephritis, though other patterns of injury also occur. What is the most common clinical features of systemic lupus erythematosus? Diffuse proliferative glomerulonephritis, though other patterns of injury also occur. Systemic lupus erythematosus and anemia, thrombocytopenia, or leukopenia is due to autoantibodies against cell surface proteins. What are common causes of death for SLE? Renal failure and infection. SLE is characterized by antinude antibody ANA, sensitive but not specific, and anti-dsDNA antibodies, highly specific. Antihistone antibody is characteristic of drug-induced SLE. What are some common causes of drug-induced SLE? 1. Hydralazine, precanamide, and isoniazid are common causes. 2. Removal of drug usually results in remission. 30% of what cases are associated with SLE? Antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome is characterized by autoantibody against proteins bound to phospholipids. 2. In antiphospholipid antibody syndrome, what are the most common antibodies? Anticardiolipin and lupus anticoagulant. In antiphospholipid antibody syndrome, what tests are disrupted? Leads to false positive syphilis test and falsely elevated PTT lab studies, respectively. What does antiphospholipid antibody syndrome result in? Arterial and venous thrombosis including deep venous thrombosis, hepatic vein thrombosis, placental thrombosis, recurrent pregnancy loss, and stroke. What does antiphospholipid antibody syndrome require? Lifelong anticoagulation. What is Sjogren syndrome? Autoimmune destruction of lacrimal and salivary glands, lymphocyte-mediated damage, type 4 hypersensitivity, with fibrosis. Sjogren syndrome is characterized by ANA and anti-ribonucleoprotein antibodies anti-SSA, Rho and anti-SSB, LA. Sjogren syndrome is often associated with other autoimmune diseases, especially rheumatoid arthritis. Sjogren syndrome results in increased risk for B-cell, marginal zone, lymphoma, which presents as unilateral enlargement of the parotid gland late in disease course. Scleroderma is autoimmune tissue damage with activation of fibroblasts and deposition of collagen, fibrosis. Scleroderma is divided into diffuse and localized types. Diffuse type of scleroderma exhibits skin and early visceral involvement. Scleroderma involves almost any organ can be involved. Esophagus is commonly affected, resulting in disordered motility, dysphagia for solids and liquids. Scleroderma is characterized by ANA and anti-DNA topoisomerase I (SCL70) antibody. Scleroderma localized type exhibits local skin and late visceral involvement. What is mixed connective tissue disease? Autoimmune mediated tissue damage with mixed features of SLE, systemic sclerosis, and polymyositis. What is mixed connective tissue disease characterized by serum antibodies against U1 ribonucleoprotein? When is healing initiated? When inflammation begins. Wound healing occurs via a combination of regeneration and repair. In wound healing, regeneration occurs via replacement of damaged tissue with native tissue, dependent on regenerative capacity of tissue. Tissues are divided into three types based on regenerative capacity: labile, stable, and permanent. Labile tissues possess stem cells that continuously cycle to regenerate the tissue. Examples of labile tissues. 1. Small and large bowel, stem cells in mucosal crypts. 2. Skin, stem cells in basal layer. 3. Bone marrow, hematopoietic stem cells. Stable tissues are comprised of cells that are quiescent G0, but can re-enter the cell cycle to regenerate tissue when necessary. What is a classic example of regeneration? In the liver by compensatory hyperplasia after partial resection. Each hepatocyte produces additional cells and then re-enters quiescence. Permanent tissues lack significant regenerative potential, myocardium, skeletal muscle, and neurons. Granulation tissue. Its formation is the initial phase of repair. In the initial phase of repair, what does the fibroblasts do? Deposit type 3 collagen. In the initial phase of repair, what does the capillaries do? Provide nutrients. Granulation tissue consists of fibroblasts deposit type 3 collagen, capillaries provide nutrients, and myofibroblasts contract wound. Granulation tissue eventually results in scar formation, in which type 111 collagen is replaced with type 1 collagen. Type 3 collagen is pliable and present in granulation tissue, embryonic tissue, uterus, and keloids. Type 1 collagen has high tensile strength and is present in skin, bone, tendons, and most organs. Collagenase removes type 111 collagen and requires zinc as a cofactor. Tissue regeneration and repair are mediated by paracrine signaling via growth factors, e.g. macrophages secrete growth factors that target fibroblasts. What results in gene expression and cellular growth? Interaction of growth factors with receptors, e.g. epidermal growth factor with growth factor receptor. Examples of mediators of tissue repair and regeneration. TGF-alpha, TGF-beta, platelet, fibroblast growth factor, VEGF. TGF-alpha, epithelial and fibroblast growth factor. TGF-beta, important fibroblast growth factor, also inhibits inflammation. Platelet-derived growth factor for endothelium, smooth muscle, and fibroblasts. Fibroblast growth factor, important for angiogenesis, also mediates skeletal development. Vascular endothelial growth factor, VEGF, important for angiogenesis. Cutaneous healing occurs via primary or secondary intention. Primary intention. Wound edges are brought together, e.g., suturing of a surgical incision, leads to minimal scar formation. Secondary intention. Edges are not approximated. Granulation tissue fills the defect, myofibroblasts then contract the wound, forming a scar. Delayed wound healing occurs in 1. Infection, most common cause, S. aureus is the most common offender. Vitamin C is an important cofactor in the hydroxylation of proline and lysine procollagen residues. Hydroxylation is necessary for eventual collagen cross-linking. What is necessary for the formation of stable collagen? Copper is a cofactor for lysyl oxidase, which cross-links lysine and hydroxylation to form stable collagen. What is a cofactor for collagenase? Zinc, which replaces the type 3 collagen of granulation tissue with stronger type 1 collagen. What are some causes for delayed wound healing? Foreign body, ischemia, diabetes, and malnutrition. Dehiscence is rupture of a wound, most commonly seen after abdominal surgery. Hypertrophic scar is excess production of scar tissue that is localized to the wound. Keloid is excess production of scar tissue that is out of proportion to the wound. Keloid is characterized by excess type 3 collagen. Keloid genetic predisposition, more common in African Americans. Keloid classically affects earlobes, face, and upper extremities. Chronic inflammation stimuli include 1. Persistent infection, most common cause. 2. Infection with viruses, mycobacteria, parasites, and fungi. 3. Autoimmune disease. 4. Foreign material, and 5. Some cancers. Where are T lymphocytes further developed? further develop in the thymus where the T cell receptor, TCR, undergoes rearrangement and progenitor cells become CD4 plus helper T cells or CD8 cytotoxic T cells. What does the TCR complex do? Recognizes antigen presented on MHC molecules I. CD4 plus T cells. MHC class II, CD8 plus T cells. MHC class I. CD4 plus helper T cell activation. Extracellular antigen, e.g., foreign protein, is phagocytosed, processed, and presented on MHC class II, which is expressed by antigen-presenting cells, APCs. B7 on APC binds CD28 on CD4 plus helper T cells providing second activation signal. How does CD8 plus cytotoxic T cell activation occur? Intracellular antigen, derived from proteins in the cytoplasm, is processed and presented on MHC class I, which is expressed by all nucleated cells and platelets. Cytotoxic T cell killing occurs via secretion of perforin and granzyme. Perforin creates pores that allow granzyme to enter the target cell, activating apoptosis. Expression of FASL, which binds FAS on target cells, activating apoptosis. B-cell activation occurs via antigen binding by surface IgM or IgD, results in maturation to IgM or IgD secreting plasma cells. B-cell antigen presentation to CD4 plus helper T cells via MHC class II. What are the steps involved in granuloma formation? 1. Macrophages process and present antigen via MHC class II to CD4 plus helper T cells. 2. Interaction leads macrophages to secrete IL-12, inducing CD4 plus helper T cells to differentiate into THL subtype. 3. Th1 cells secrete IFNY, which converts macrophages to epithelioid histiocytes and giant cells. How does X link to gammaglobulinemia present? After 6 months of life with recurrent bacterial, enterovirus, e.g., polio and Coxsackie virus, and Giardia-Lamblia infections, maternal antibodies present during the first 5 months of life are protective. In autoimmune disorders, what does loss of self-tolerance involve? Self-reactive lymphocytes are regularly generated but undergo apoptosis, negative selection, in the thymus, T cells, or bone marrow, B cells, or become anergic, due to recognition of antigen in peripheral lymphoid tissues with no second signal. What is systemic lupus erythematosus? Systemic autoimmune disease, antibodies against TBE host damage multiple tissues via type 2, cytotoxic, and type 3, antigen-antibody complex, hypersensitivity. Clinical features of systemic lupus erythematosus include fever and weight loss, malar, butterfly, rash, especially upon exposure to sunlight, arthritis, pleuritis and pericarditis, involvement of serosal surfaces, CNS psychosis, renal damage, endocarditis, myocarditis, or pericarditis can affect any layer of the heart, anemia, thrombocytopenia, or leukopenia, due to autoantibodies against cell surface proteins. Renal failure and infection are common causes of death. How does Sjogren syndrome classically present? As dry eyes, keratoconjunctivitis, dry mouth, xerostomia, and recurrent dental caries in an older woman, 50 to 60 years. Can't chew a cracker, dirt in my eyes. What is CREST syndrome? For localized type scleroderma, calcinosis, anticentrineria antibodies, Raynaud phenomenon. Esophageal dysmotility, sclerodactyly, and telangiectasias of the skin. Repair. Replacement of damaged tissue with fibrous scar occurs when regenerative stem cells are lost, e.g., deep skin cut, or when a tissue lacks regenerative capacity, e.g., healing after a myocardial infarction. How are TLRs activated? Pathogen-associated molecular patterns PAMPs that are commonly shared by microbes, CD14, a TLR, on macrophages recognizes lipopolysaccharide, a PAMP, on the outer membrane of gram-negative bacteria. Cyclooxygenase produces prostaglandins PGA. PGI2, PGD2 and PGE2 mediate vasodilation and increased vascular permeability. PGE2 also mediates pain. (5-lipoxygenase) produces leukotrienes, Lieutenant A. LTB4 attracts and activates neutrophils B. LTC4, LTD4 and LTE4, slow-reacting substances of anaphylaxis, mediate vasoconstriction, bronchospasm, and increased vascular permeability. Fever. 1. Pyrogens, e.g., LPS from bacteria, cause macrophages to release IL-1 and TNF, which increase cyclooxygenase activity in perivascular cells of the hypothalamus. 2. Increased PGE2 raises temperature set point. Step 3. Adhesion. 1. Cellular adhesion molecules, ICAM and VCAM, are upregulated on endothelium by TNF and IL-1. 2. Integrins are upregulated on leukocytes by C5a and LTB4. 3. Interaction between CAMs and integrins results in firm adhesion of leukocytes to the vessel wall. What are the clinical features of LAD? Delayed separation of the umbilical cord, increased circulating neutrophils due to impaired adhesion of marginated pool of leukocytes, and recurrent bacterial infections that lack pus formation. Step 5. Phagocytosis. 1. Consumption of pathogens or necrotic tissue. Phagocytosis is enhanced by opsonins, Ig and C3a. 2. Pseudopods extend from leukocytes to form phagosomes, which are internalized and merge with lysosomes to produce phagolysosomes. Step 6. Destruction of phagocytosed material. 1. O2-dependent killing is the most effective mechanism. 2. HOCL generated by oxidative burst in phagolysosomes destroys phagocytosed microbes. How does O2-dependent killing occur? O2 is converted to O2 by NADPH oxidase, oxidative burst. O2 is converted to H202 by superoxide dismutase, SOD. H202 is converted to HOCL, bleach by myeloperoxidase, MPO. What does CGD lead to? Recurrent infection and granuloma formation with catalase-positive organisms, particularly Staphylococcus aureus, Pseudomonas cepacia, Serratia marcescens, Nocardia, and Aspergillus. Nitrobue tetrazoleum test is used to screen for CGD. Leukocytes are incubated with NBT dye, which turns blue if NADPH oxidase can convert O2 to O2, but remains colorless if NADPH oxidase is defective. What do macrophages do? Ingest organisms via phagocytosis, augmented by opsonins, and destroy phagocytosed material using enzymes, e.g., lysozyme, in secondary granules, O2-independent killing.